Good evening to all of you. Respected delegate postgraduates and all medical practitioners. On behalf of the Department of Internal Medicine, I'm very happy to invite all of you for our CME Stumbling Blocks to Stepping Stones based on COVID-19. Our intention behind this CME is to explore the common issues that we face and the ways to surmount them. COVID-19 is truly an unexpected blow to the medical sciences. We are trying our level best to come out of the pandemic. We are also conducting the CME as an online event, admitting the limitations. Still, we have tried our level best to convey the best facts and the basic facts which will stimulate the thinking process in all of you, especially the younger generation. As an added event, we have included PG case discussion by eminent faculty members like Sharma sir, Anandaguna sir, and Uday Kumar sir, which will invariably be an enlightening event and experience for all of us. Before I conclude, we are happy to inform you all and request your blessings for our YouTube channel, a new venture from our department, which will be launched by our medical director, Dr. Prem Nair sir. I also take this opportunity to thank our organizing secretary, Dr. Subhash, and all other faculty members who are behind this CME. With all these words, let me move on to the topic discussion. A new venture from our department, which will be launched.
You're on, correct.
Thank you, MGK sir, for the message. Now I humbly invite Dr. Prem Nair, Medical Director of Amrita Institute of Medical Sciences, to officially launch our YouTube channel and the event. Over to you, sir.
Thank you, Dr. Subhash. It's indeed a privilege for me to be here to inaugurate this grand event with a 3-day CME Amrita Medicine Update online, this time owing to COVID, and called, very interestingly, Stumbling Blocks and Stepping Stones. Let me congratulate all of you, particularly Dr. M.G.K. Pillai, Head of Department of Medicine, along with Dr. Subhash, who put it all together with outstanding faculty in all different specialty areas. We have Dr. R.N. Sharma, Dr. Anand Kumar, Dr. Vasant, Dr. Girish, Dr. Akhilesh, Dr. Divakar, Dr. Renoy, Dr. Deepu, all outstanding stalwarts from our internal medicine and subspecialty programs. I'm sure I must have missed many. Please forgive me. We have, with the blessings of our beloved Chancellor Amma, we would like to welcome one and all to this important internal medicine update, which is being conducted online. As a new feature, we are introducing postgraduate discussions for the first time for the benefit of undergraduate and postgraduate medical students. We are also pleased to inaugurate the new YouTube channel referred to as Amrita Medicine Update, which will be hosting this entire CME, and in the future may be used for hybrid teaching, case discussions, academic sessions, and skill demonstrations for the benefit of doctors and medical graduates everywhere. Hope you'll have an enjoyable time and interact with our outstanding faculty. Thank you all very much for your precious time. And interact with our outstanding faculty. Thank you all very much for your precious time.
Thank you, Dr. Prem sir, for that wonderful inauguration. So let's start this program with the first speaker. It's none other than our beloved Dr. M.G.K. Pillai sir. Dr. M.G.K. Pillai is currently the Professor and HOD of the Department of General Medicine, Amrita Institute of Medical Sciences, Kochi. He is an eminent teacher with excellent oratory skills, a clinician and academician par excellence. He has vast experience in teaching undergraduates and postgraduate students, and is a proud author of multiple research papers. I welcome Dr. M.K. sir to start the session. Thank you.
Good evening. The topic of discussion is the cardiovascular complications in COVID-19. The pandemic was actually a threat to the medical profession. We have seen significant morbidity and mortality due to this virus infection. Though primarily the disease affects the respiratory system and gastrointestinal system, there are significant increase in the mortality due to involvement of the cardiovascular complications. Hence, we have selected all the relevant systems and the complications to explain the morbidity and mortality in COVID-19. Though primarily the disease affects the cardiovascular complications COVID-19, we will start with the pathophysiology and the complications and also the treatment of some of the important aspects. See, before we go into the pathophysiology, we have to see what is this COVID virus. It belongs to SARS group, and you can see the and also spike protein projections over the virus. I know you might have You might have been seeing so many CMEs and you are familiar with all of it. But still, these projections means especially the spike protein and envelope protein. These some of the proteins are very, very important to explain the pathophysiology. These spike proteins, membrane proteins, envelope proteins. Spike and envelope are very, very important, and also other proteins. These are all required for entry into the cell and then the multiplication. And also then coming out means the generation of next group of virons. Spike proteins, membrane proteins, envelope proteins. Spike and envelope are very, very important. The virus is near the cell. The membrane fusion is the first event to occur. Monoclonal antibodies and convalescent plasma, which we use as therapeutic measures against this virus, act at this level, preventing entry or neutralizing the virus at that. The virus is near the cell. What is the requirement for the virus to enter into the cell? It is the TMPR SS protease that is inside. That will cleave the S, that is the spike protein. Or ritonavir. So how the medicines become effective, that also can be explained from this slide. And from proteolysis, the genome goes into RNA polymerase reaction. This is the stage with which so many virons will be produced after packing with the Golgi complex. That also can be explained from this slide. And from nucleic acids, that is, this step can be prevented by the commonly used medication, remdesivir. And once these virons are again inside a cell line, it can come out with exocytosis and infect another person. That is, this step can be prevented by. Now, we have seen that pathophysiology, ACE2 receptors are widely distributed in all organs. So, the abundant number of these ACE2 inhibitors in the alveolar epithelial cells and enterocytes in the small intestine, the two organs that are direct contact with the virus to entry into the body. The endothelial cells And we have seen that cardiomyopathy.
Next.
Are where
Increase in the mortality due to involvement of the cardiovascular complications. Hence, we have selected all the relevant systems and the complications to explain the morbidity and mortality in COVID-19. The cardiovascular complications COVID-19, we will start with the pathophysiology and the complications and also the treatment of some of the important aspects. See, before we go into the pathophysiology, we have to see what is this COVID virus. It belongs to SARS group, and you can see the spike protein projections over the virus. I know you might have been seeing so many CMEs and you are familiar with all of it, but still, these projections mean especially the spike protein and envelope protein. These some of the proteins are very, very important to explain the pathophysiology. These spike proteins, membrane proteins, envelope proteins. Spike and envelope are very, very important, and also other proteins. These are all required for entry into the cell, and then the multiplication, and also then coming out means the generation of next group of virons. See, the virus is near the cell, The membrane fusion is the first event to occur. Monoclonal antibodies and convalescent plasma, which we used as therapeutic measures against this virus, act at this level, preventing entry or neutralizing the virus at that time. What is the requirement for membrane proteins, envelope proteins? Spike and envelope are very, very important, and also other proteins. These are all required for entry into the cell, and then the multiplication, and also then coming out means the generation of next group of virons. See, the virus is near the cell. The membrane fusion is the first event to occur. Monoclonal antibodies and convalescent plasma, which we used as what is the requirement for the virus to enter into the cell? It is the TMPR SS protease that is inside. That will cleave the S, that is the spike protein, and which will allow or easify the union of the virus with these receptors, ACE2 receptors, and which will help the virus to come into the host cell, that is endocytosis. This endocytosed virus then comes out or releases the viral genome, RNA, which enters in the ribosome and translation occurs. Subsequent proteolysis from polypeptide chain can be prevented by, or we suppose can be arrested by, two drugs, lopinavir or ritonavir. So how the medicines become effective, that also can be explained from this slide. And from proteolysis, the genome goes into RNA polymerase reaction. This is the stage with which so many virons will be produced after packing with the Golgi complex. This nucleic acid, that is, this step can be prevented by the commonly used medication remdesivir. And once these virons are again inside a cell lining, it can come out with exocytosis and infect another person. Now, we have seen that pathophysiology, ACE2 receptors are widely distributed in all organs. So the abundant number of these ACE2 inhibitors in the alveolar epithelial cells and enterocytes in the small intestine, the two organs that are direct contact with the virus to entry into the body. The endothelial cells and cardiomyocytes and the pericytes in the heart will be affected with this virus. That is how the cardiovascular complications occurs. And the ACU2 receptors, that is the S protein binding to ACU2 receptor, require the, already I have told about the TMPRSS2 mediated proteolysis. Therefore, expression of both ACU2 and TMPRSS2 is essential or it's a requirement or SARS-CoV-2 virus to enter into the host cells. Again, viral entry, binding, ACE2, the same picture, that is the biggest one we have seen, and in what way it affects the system. Direct cytotoxic effects. One, the virus entering and changing the internal environment of the host cell, that is damage. Second, dysregulation of the RAAS, that is because ACE2 receptor is affected, renin angiotensin aldosterone system is affected. That is why many patients develop complications of potassium metabolism, hypokalemia. So this is the step occurring because of the dysregulation of the renin angiotensin aldosterone system. Third is the endothelial cell damage and thromboinflammation. This occurs with endothelial cell damage and apoptosis and endothelial inflammation, leading to decreased fibrinolysis, which favor thrombosis and also increase thrombin production. And the next step is the dysregulation of the immune system, that is the lymphopenia, inhibition of interferon, which is protective, and also hyperactive immune system because of the release of cytokine. So all this will lead to the thrombotic complications in the vessel, capillary, small vessels. You can see the blood vessel, increased level of IL-6 and tumor necrosis factor, and the inflammation inside of the vessel. The von Willebrand factor is exposed. We'll see in the coming slides, and favoring platelet aggregation, fibrin development, and thrombosis. Three progressive clinical phases in COVID. Early infection stage, clinical manifestation driven by actively replicating virus, depends or vary from person to person. Some will have mainly body pain and fever, some may not have fever, depending on the age and comorbid illnesses. Second phase is pulmonary phase, respiratory symptoms, especially throat pain, where the viral application occurs and the host immune system or response is activated. Third is the hyperinflammation, that is always around the seventh day onwards, the pathophysiological process of inflammatory response comes out. And see the two phases interacting. So it is in the early stage viral response phase occurs, but part of this phase extends into the second phase and the beginning of the host inflammatory response. So a significant number of people can have both. A febrile response is this stage, that is the pulmonary phase, stage 2, around 5th day, can be due to either of these two. A careful blood examination, especially focusing to C-reactive protein, ferritin, etc., are important here, which will help us to recognize what is the reason for the second onset of fever. And the third is the hyperinflammatory phase, where the fever can lead to complications. So the first stage, you can see that changes in the blood is such lymphopenia commonly were noticed, and the second stage, shortness of breath, hypoxia develops, and also you will see the imaging changes, that is there will be changes in the X-ray and the CT required cases, and the final stage you will see membrane leak because of capillary leak syndrome, where multi-organ dysfunction occurs, and elevated inflammatory markers much more than the initial phases you will see here. And if you measure the IL-6, you can see a definite increase. A D-dimer denotes either a thrombotic event or even pulmonary embolism. See the other manifestations: neurological, renal, hepatic, gastrointestinal, thromboembolic, cardiac, endocrine, and dermatological. See, it can affect any system, any part of the human body. Even in the skin, you can see the changes. It can even present with urticaria. We've seen a significant number of cases of urticaria during this period. So this bidirectional change, that is CVS and COVID-19, that is, when we plotted, means combine many studies and graphs, you can see a 8% increase in the mortality compared to other system involvement, especially when the cardiovascular system is involved. So cardiac injury means around 8 to 10% increase in the risk, that means mortality. And finally, a significant number of histopathological studies were undergone during this pandemic, and the immunostaining showed lymphocytic myocarditis and infiltration of it with the myocardium into the myocardium and myocyte injury. Next is again the subendocardial CD4 necrotic myocytes with C4D plus and right ventricular myocardium showing subendocardial C4D plus necrotic myocytes were unique in COVID-19 myocarditis. Again, immunofluorescence staining of the intravascular microthrombi with the spatial association of the neutrophils. This gray area, that is the area where it is seen. Cardiovascular manifestations, again, direct cardiovascular sequelae or indirect, which was much more common due to myocardial injury, acute coronary syndrome, cardiomyopathy, acute cor pulmonale because of thromboembolism, arrhythmias, shock, and thrombotic complications. Again, myocardial injury with elevation of biomarkers above 99% of the upper reference limit in 20 to 30% of hospital patients with COVID-19, with the higher rates up to 55%, and those with pre-existing diseases, that is comorbid conditions. Biventricular cardiomyopathy, 7% of critically ill patients had cardiomyopathy. So this is going to become an important reason for the cardiomyopathy in subsequent years. Isolated right ventricular failure was seen in significant number and reported, but pulmonary embolism was lacking. So RV strain and failure secondary to COVID-19 was also noticed. Going to the history, first myocarditis case was detected in 80s in a 43-year-old man. This is reported. But this COVID-19 was unique in the spread from one person to person very rapidly. But this is something which was remaining as one or two cases coming and going like that. So anyway, this was reported in 80s in a 43-year-old man. Possible mechanism of acute myocardial injury and myocarditis in SARS-CoV-2. One is direct virus-induced damage. We have seen that viral entry with ACE2 receptor help. And second is cytokine storm and inflammatory response, which can also damage the myocardium. And third is endothelitis. We have seen the previous slides. And the immunothrombotic mechanisms will be activated. And finally, when ischemia develops, demand-supply mismatch occurs and dysfunction of either ventricle can occur. Takotsubo is also seen in significant number, maybe because of fear and subsequent sympathetic overactivity. The picture again demonstrates all things that we have discussed here, and you can see even the capillaries or microvasculature dysfunction that is getting involved in COVID-19. And you can see the plaque rupture. So inflammation, plaque rupture, all these can lead to complications in the myocardium. Same thing explained in a better way, that is the virus damaging entering the myocardium, damaging, and after the entry, facilitating the activation and binding to cell entry AC2. That is, we have seen a basic cell concept first. Again, with reference to myocytes, we are showing the same thing. See what is happening in the capillaries. The pericytes and endothelial cells getting damaged. So the virus damaged the pericells. So the pericytes are actually helping the endothelium to function properly, leading to endothelial dysfunction. So injury of these cells leads to code, that is endothelial dysfunction. Third is again lung involvement, inflammation, and finally this will also affect the myocardium. The cytokine released will injure the myocardial cells and damaging it. SARS-CoV-2 and endothelial cell dysfunction, again focusing to the endothelial level. That is direct damage, subsequent exposure of von Willebrand factor. That is, once that factor is exposed, because the endothelial cell covering it was damaged and it has moved away. So the platelet will aggregate, the fibrin will accumulate, and thrombosis will occur. And already we have told about cytokines. What is the risk about COVID-19 and CVS? Older age, comorbid, that is cardiovascular disease, lung, renal, diabetes, systemic inflammation of any other kind, coagulation abnormalities, severe illness, multi-organ dysfunction, any other reason, or immobility, that is lack of exercise. And the complication you have seen, it can be myocardial complications, myocardial infarction, heart failure, cardiomyopathy, arrhythmias, and shock and cardiac arrest. Venous thromboembolic event also can lead to local and systemic effects. TD for the chest pain in COVID-19. Type 1 myocardial infarction, ACS, common one. Type 2 is secondary to the complications that we have already seen. Then the acute inflammation myocarditis that leads to myocardial dysfunction. Pulmonary embolism leads to direct complications in the pulmonary vasculature, subsequent cardiorespiratory failure, and non-cardiac but respiratory complications, pleurisy, GI. All this also leads to chest pain. So what will you do? As usual, you will take an ECG and echo, and you will see the changes that will happen. What are the symptoms that you see? Chest pain, dyspnea, rhythm disturbances, and ventricular dysfunction. You will send protein, that is troponin, liberated chemicals from the damaged myocardium. And you will take an ECG which may show an ACS pattern, STT changes, and with which you will say which is mild or serious. Then the echo will show regional wall motion abnormality, and which will help us to distinguish between myocarditis leading to cardiac failure or myocardial infarction. And echo and ECGs are the gold standard, that is the markers of illness severity and correlate with the worst outcome. And troponin is also very, very important, which will increase the risk of adverse outcome. That is, elevated troponin indicates increased risk and predicts the mortality. Then COVID-19 SIRS plus hypercoagulability called increased risk of atherosclerotic plaque rupture, which can lead to acute myocardial infarction. So this hypercoagulable stage is very important, along with the systemic inflammatory response. If it is STEMI and COVID-19, management is as usual. If it is an emergency, we cannot wait for the reports. You have to go ahead with the PCI and save the life. If you are suspecting COVID-19 and it is a non-ST elevation myocardial infarction, diagnosis testing for COVID you can wait. That means catheterization you can postpone. But if it is confirmed case, we will go ahead with the anticoagulants, antiplatelets, and statins because it is only STEMI. And if it is hemodynamically unstable, we have to consider it as just like STEMI and go ahead with the PCI. So the mechanisms, how this elevation of cardiac biomarkers occurs, that is especially troponin. It can be ischemic. We have explained all this in the last slide. And hypoxia, septic shock, and tachycardia, which will lead to secondary damage to myocardium, that is type 2 myocardial infarction. Again, non-ischemic causes, which include myocarditis, pulmonary embolism, and Takotsubo syndrome. So the direct effect also can lead to liberation of these troponins. This is acute. Once there is a chronic cardiac event, there can be an elevation with the existing event plus due to the acute problem. See, the high sensitivity cardiac troponin concentration should be interpreted as quantitative variables. That is, higher the troponin level means if it is very high, consider myocardial infarction, myocarditis, and Takotsubo shock. If it is only a small quantity, it can be heart failure, pulmonary embolism, ARDS, etc. If it is a very mild, only chronic cardiac disease. So like that, the interpretation also depends upon the level. And see, spectrum of echocardiography abnormalities in the patients with myocardial injury and COVID-19. LV wall motion abnormalities, see, it can interact with the right ventricular dysfunction and diastolic dysfunction. So there is always an overlap between all these, and pericardial effusion also comes here. So various reasons, whether it is global LV dysfunction or RV dysfunction or diastolic dysfunction, all these can be detected with echo, and we can also find out what is the main reason for the cardiac problem. What are the European Society guidelines in patients with a cardiac problem, especially NSTEMI? This is a very high risk group, intermediate risk and low risk. If it is very high risk, see, if that is hemodynamic complication, shock, etc., and life-threatening arrhythmias are there, then patients immediately invasive procedure is our, that is, follow STEMI pathway in the very high. If it is a high risk, early invasive we can plan, that is less than 24 hours. Again, monitoring is very, very important, and you may have to parallelly wait for the code report. Intermediate, without much complications, we can non-invasive testing. We can wait without cath study. Very low, that is test for SARS code, you can wait and you can manage medical line. What is acute heart failure and cardiomyopathy? Various ways it is presenting, very difficult to differentiate. But acute heart failure can be primarily presenting manifestation. That's why a few patients presented with pulmonary edema picture, and subsequently the echo showed significant cardiac dysfunction. And it has been seen that 23% of the patients with this presentation for COVID-19 and cardiomyopathy was significantly much more. But this picture varies from center to center, and this is actually a combined picture in a few centers. Another study showed heart failure 24% in patients with increased risk, that is another group. So whether it is biventricular cardiomyopathy or single, the mortality rate was very high. And among those with heart failure, nearly half did not have a known history of hypertension, or that is, no other risk factors for cardiomyopathy was there in patients with heart failure. So new cardiomyopathy versus an exacerbation of previously undiagnosed heart failure. Some group we cannot predict what happened because we did not have an echo report with most of the patients. And what is the importance is we can avoid administering fluids to those with LV dysfunction. So aggressive fluid therapy is very careful, and we can manage if you do an echo in suspected cases and find out the cardiac dysfunction. Etiology of heart failure, again, already we have told, direct or indirect, and also uncovered or exacerbated the previous existing illness by the COVID-19, or it can be acute coronary. diagnostic workup mainly with NT, pro-BNP, troponin markers, transthoracic echo, MRI very rarely but may help us for structural abnormalities, and diastolic heart failure, and also we can make out with echo. Move ചെയ്യുന്നില്ല. ആ Now the diagnostic workup for the patients: NT-proBNP, troponin markers, transthoracic echo, MRI. All this will reveal the exact problem and will help us to get the diagnosis early. Dysrhythmias is another important complication increasing mortality. The commonest presentation was palpitation, and the commonest type of dysarrhythmia was sinus tachycardia. That is resulting from multiple simultaneous causes, that is hypoperfusion, fever, hypoxia, anxiety. Of course, all of you know anxiety was a very important reason for sinus tachycardia. It is invariably seen in most of the patients, and even to patients that are coming to OPD, and in many patients even coming to OPD without any COVID suspicion. So there was a seasonal increase in the heart rate, and it was due to sinus tachycardia. One study, 17% of the hospital patients and 44% of the IC patients with COVID-19 had increase in the heart rate, mainly due to sinus tachycardia. Dysrhythmias may occur settling of viral illness, hypoxia, inflammatory stress, and abnormal metabolism. So these were the reason for increase in the heart rate, and we have seen a significant number with atrial fibrillation, and in myocarditis patients, ventricular tachycardia, and also possibly VF, where the patient went into cardiac arrest. So once there is elevated troponin with dysarrhythmia, myocardial injury should be suspected, and myocarditis and ACS should be ruled out. Coming to the final part, venous thromboembolic events. Again, the same thing: systemic inflammation, abnormal coagulation status, and multi-organ dysfunction. Critically, all this will lead to venous thromboembolism, and COVID-19 promoted because of the elevated thrombotic state. So what you will see is elevated D dimer. And one study of 25% with COVID-19 pneumonia, elevated D dimer was present in all patients with a median 6.06 microgram per ml. That means what we observed is many patients with suspected pneumonia actually were found to have pulmonary infarction and inflammation of the blood vessels rather than infection. This was observed in many centers. Patients with confirmed pulmonary embolism on CTPA demonstrated a median D dimer level and D dimer level of minimal increase. Anyway, whatever is the level, an increased level led to more death rates in hospitalized patients. So D dimer was helpful in predicting the mortality in most of the cases, and also follow-up of complications. Another often forgotten thing was the medication that are interfering with or producing complications in COVID-19 management. Remdesivir, for example, it was actually, we have seen that RNA polymerase inhibition. So this medication produced hypotension arrhythmias. Another was lopinavir. This is also almost same way it interacts, and also it interacts with anticoagulants antiplatelet statins and antiarrhythmic drugs. Prolonged QTC were noted in few cases. So use of drugs were also resulted in increasing the complication. Favipiravir, again that is RNA polymerase reaction inhibition, interacts with anticoagulant statins and antiarrhythmics. And a few cases it has produced hemolytic anemia. So commonly used medications. Azithromycin, I think, maximally used medication because often we wanted to prevent bacterial infection as well, and found to be very effective in most of the cases. So this again interferes with the protein synthesis. There is a mechanism of action, and it can again interact with the statins, anticoagulants, and antiarrhythmic drugs, and QT prolongation in few cases. Chloroquine. Initially, this was one of the drugs maximally used. Subsequently, the use was actually a question mark, but even that also has caused some damage to the cardiovascular system. Interferon, very good immune support, but myocardial toxicity was reported, and use had to be very cautious. Steroid was actually one of the backbone in the management of inflammatory problems, and because of fluid retention and interference with some of the drugs, it can also produce complication. But compared to other drugs, it is same. Tocilizumab was, which is supposed to inhibit IL-6, relatively safe, but often it has produced an hypertensive response. In some centers, you don't have much experience. So, coming to history in the making, many patients' feedback. From the patients, we have got a term now, long COVID. What is happening? Since years, we are with this organism. It has changed the history of medicine. It has become a challenge for us. So long COVID is going to live with us. But luckily, the intensity of the disease is coming down, and the mortality also is coming down. So though we are going to live with COVID-19 virus, we will carefully look into the complications that it can produce on a long-term basis. So the symptom that is what more than 12 weeks, we have seen some patients, especially rheumatological problems. So we will carefully watch them, and we will have to find out a treatment line to prevent further complications. Again, multi-organ involvement requires long-term complications. So long COVID is becoming an important terminology, especially coined by the patients. So multi-center prospective study from many centers also have found that significant number of patients had these complications of multi-organ involvement and requires follow-up. So, what is the take-home message? COVID-19 is associated with the number of cardiovascular complications. Take-home message. What is the take-home message? COVID-19 is associated with the number of cardiovascular complications, including myocardial injury, myocarditis, acute myocardial infarction, heart failure, dysrhythmias, and venous thromboembolism. Some of the medications can interfere with the cardiac functioning and produce complications. Ongoing research or understanding about the disease and the long-term effects has to be there, and standardization and validation of the non-invasive biomarkers are important. And it is important when administering IV fluids and avoid over-aggressive fluid replacement, because there can be complications about the myocardial function. So finally, questions in mind. Are we satisfied with the present line of management for COVID-19? We may have to wait for the answer. How far we were able to prevent the spread and complications of COVID-19 infection? Is this pandemic beyond our present knowledge? In science means may require more research to answer it. So time will give us an answer. Peacefully we have to wait. Thank you.
Okay, and now we move on to the question answer session. Before we start, I just want to make a few important announcements. That is, due to the present ongoing COVID pandemic, we are forced to pre-record some of the video sessions because of the COVID pandemic. And one more point is, if those who are attending the session, please register so that we'll be able to provide you the certificates at the end of the conference. Now we'll move on to the question answer session. We have a few questions. Sir, somebody has asked, like, what is tracheal tug, sir? Over to you, sir. Pillai, sir? Yes, sir. Somebody has asked about what is tracheal tug, sir?
Actually, hello, Subhash. This is actually connected to the case presentation, and you will answer. Yeah, this the tracheal tug is an inward pulling of the trachea when the patient is seen in from the front. That means when the patient is breathing, you'll see the trachea is going down. This unusual movement of the trachea we can even demonstrate by keeping the hand, that is the thumb and index finger, over the trachea and asking the patient to breathe. So this inward pulling can be felt by fixing the thumb and index finger over the trachea. This is also mentioned to occur with aneurysms of the aorta, where actually with the pumping of the heart, the trachea will move. So in nowadays, it is rarely used as a diagnostic, but previously this was very well diagnostic in hyperinflation of the chest, as well as it was helpful in diagnosing aneurysm of the aorta.
Actually, due to thank you, sir. Thank you very much, sir. As due to shortage of time, we initially had a lot of technical glitches, so we are already running behind schedule. So we'll quickly move on to the next schedule, next session. Thank you, sir. Thank you very much, sir.
Thank you.
Over to you, Rohit. Over to you, Rohit.
Thank you, MGK sir, for that very informative session. Next on the mic, we have Dr. Vivek Nambiar. He's completed his graduation from Bombay University, and he has a fellowship in stroke and vascular neurology from the University of Calgary. He currently heads the stroke division on the Department of Neurology in Amrita Institute of Medical Sciences. He is also a recipient of the famous Paul Dudley White International Scholar Award, which is given by the American Heart Association. He also has 30 plus publications in both national and international journals. Over to you, Vivek sir.
A very good morning to all. First of all, I thank Dr. MGK Pillai for giving me this opportunity. And so this rings in brain, an easy approach. So this is a rather a radiological topic, but there are a lot of clinical scenarios involved in routine practice. So we'll start with a case scenario. So this is a 42-year-old man. He had got subacute headache for 4 weeks, and he had mild left hemiparesis for last 5 days, but he got improved, but the headache persisted. So he went to a hospital where CT scan was taken. There was a hypodense lesion with some hypertensity and with ring enhancement. So he was referred for neurosurgery for biopsy. So this is a very common scenario because patient will come with various neurological issues, and we will take a CT scan at random, and because we suspect something organic in the brain, so we see a lesion like this. And so how to go ahead with this type of lesion? Is it because in the situation patient is improving, is it important to confirm, or shall we take another imaging, or the patient would be referred for further intervention? So this patient has undergone a stereotactic biopsy from the lesion that was a subacute infarct. So this type of situation can arise if we had better imaging and better thinking about the diagnosis. We could have avoided this biopsy. However, it was conclusive that it was an infarction. So why this ring enhancing lesion happened? So what are the causes of enhancement? So enhancement means we give contrast, the IV contrast, and then the brain would be seen in a different way because of the uptake of the contrast. So what are the different types of enhancement and what are the causes of the enhancement? So there is something in the interstitial enhancement. So we know that the brain is protected from chemicals and outside materials by blood-brain barrier. And when the blood-brain barrier breaks down or there is increased permeability, there can be a outside extravasation of the materials in the circulation. So that can lead to the contrast can extravasate, which will lead to interstitial enhancement. So it is outside the circulation. So, but we can also see extra intravascular enhancement where we would see lot of contrast uptake, but this uptake would be due to the increased blood supply. So you may see there's a lot of vessels you will be seeing as like enhancement, but it is actually only intravascular enhancement. So there will be increased vascularity or there is vasodilation. So sometimes we will see extra parenchymal enhancement. That means it is not inside the parenchyma, but in the meninges. So you can see thickening of the meningeal layer with enhancement. So new blood vessels, active inflammation, cerebral ischemia, and pressure overload can produce alterations in the permeability of blood-brain barrier and can cause enhancement. So we can see different type of enhancement, nodular enhancement here, like where you get a meningeal deposits of nodular secondaries here, or you can have patchy enhancement, or you can have ring-like enhancement. This is our focus of discussion, ring-like enhancement, or this is actually a large glioblastoma lesion with irregular enhancement. So we'll come to that later. So it can be pachymeningeal enhancement, or it could be subarachnoid enhancement. So this could be thin linear enhancement. Like you can see here, the pile layer or arachnoid pile layer is involved rather than the dural layer. So dural enhancement is outside, and the pile enhancement can be into the sulci. So this is one of the type of special enhancement which would be seen in meningitis. So you can see meningitis, you can see this type of pile subarachnoid enhancement. So this is a type of unilateral, that means a focal lesion like a deposit disease, like neurosarcoidosis, an infiltrating disease, or IgG related meningitis. So that could be focal. So similar type of enhancement, but focal. Here you can see diffuse bilateral thick lumpy nodular enhancement. This is seen with carcinomatous meningitis. So it's very much infiltrating and spreading disease with a lot of vascularity that lead to increased enhancement in this. So we have complete and incomplete ring enhancement pattern. I told you about the dural based enhancement. This is a meningioma. You can see the dura here, and there is a dural tail, and there is an enhancement lesion. So this is a meningioma. This is a dural tail. And then we have dural arachnoid enhancement. You can see those coming down to different part of the layers. And your pia arachnoid means it will be going into the deeper into the sulci. So there'll be gyral enhancement exactly over the gyrae only, usually seen with subacute infarct. And we can have smooth ring enhancement, especially in the abscess. Irregular ring, we'll come to that in different slides. So this is something cyst-like enhancement with nodularity. This is due to the pilocytic astrocytoma in the cerebellum. So we have open ring enhancement where we get in demyelination. We'll come to that later. So this is cerebral cyst with a nodule, especially smaller ones, colics and the neurocystic sarcosis. And we have thin periventricular enhancement in lymphoma, thick irregular periventricular enhancement again in lymphoma. So this is a classical example of a brain abscess where there is a thin layer of enhancement and there's some perilesional edema here. So this is the pile arachnoid enhancement where the enhancement engages into the smaller sulci. So that is what pile arachnoid enhancement is. So gyriform enhancement usually we see in subacute infarct. You can see the gyre only enhancing because of the blood-brain barrier will be lost in this area. You can see this type of enhancement. Also, in this situation, actually we have bilateral gyriform enhancement in the temporal lobe. This is due to the encephalitis. So encephalitis and subacute infarct can produce enhancement in this pattern. So this is the common type of enhancement seen with the herpes encephalitis. But if it is unilateral and focal, we would think about subacute infarct. So this is another type of same type of enhancement due to subacute infarction. So pachymeningeal enhancement, this is one thing where you will see severe dural enhancement, which is due to usually either due to the intracranial hypotension, where there will be stretching of the dural layers and there will be more enhancement. So this you can see in the MRI, you can see that enhancement only in the dura rather than into the sulci of the sulci and gyri. You're not seeing that. So this outside, that is the dural enhancement. So what are the common cause of ring enhancing lesion? There is an acronym called magical doctor. So metastasis, we know metastasis produces a ring enhancing lesion. Abscess, we have mentioned about abscess, glioblastoma multiforme, that is the primary brain tumor, high grade astrocytoma. Infarct in the subacute phase will have, and also contusion, that's cerebritis. AV malformation, it's like different type of AV malformations. Lymphoma, we know it's an enhancing lesion. Demyelinating lesion like multiple sclerosis or tumefactive demyelination, and also radiation necrosis, also resolving hematoma. So these two situations are tricky because radiation necrosis sometimes get confused with the tumor recurrence in a patient who had surgery and radiation for glioblastoma. So resolving hematoma is also a tricky thing. When somebody with a hematoma, intracerebral hemorrhage, come for a review and complains of headache, we think about recurrent hemorrhage. So we take a CT scan, we would be seeing a ring enhancing lesion, so which may mimic a tumor. So this is a resolving hematoma. So this is the acronym for the cause of ring enhancing lesions. So how will you approach when you see a ring enhancing lesion? So we should have a clinical approach because we are not seeing the scan alone. We are seeing patients and their clinical presentation. What are their background? How is the headache? What are the other symptoms? So we have a lot of radiological clues on which we will be trying to look into more, and also pathological confirmation in selected situations. We would not go for brain biopsy all the time. We will try to utilize these two approaches, clinical approach and radiological clues, to get into a conclusion, and then we'll give adequate treatment. So generally we'll classify them into immunosuppressed patient or immunocompetent patients with or without systemic disease, systemic symptoms and signs. So this is just, see, this is a patient if this patient had non-immunocompetent patient with some history of heart disease and presenting with a headache and hemiparesis on the right side of the aphasia. So this is a case, you can see there is a thin rim of T2 hypo intensity with inside hyperintensity. You can see that this is T2 MRI. You can see the edema around the lesion, and also there is T2 hyperintensity inside. On contrast, there is a ring enhancement, and and also the CT, you can see there is a this actually forms abscess. This because a smooth layer is due to the granulation tissue formation, because inside there is a necrosed tissue. You can see restricted diffusion. So the restricted diffusion and ring enhancement suggest either it's an abscess or it could be a high-grade glioma. So here, if the patient is having any symptoms of fever, headache, and any other propensity for systemic infection, more likely to be brain abscess. So the brain abscess will be the first diagnosis. So sometimes plain CT will show this type of hypodensity inside peripheral rim of hyperdensity, and there can be daughter abscesses. So we have T1, there is core slightly hyperintense, and GADO, there will be ring enhancement. You can see bright restricted diffusion, and there will be, if you do the spectroscopy, you can see lactate and lipid amino acid peaks. So same thing. We can have these type of peaks. You can see the rim here, very clear cut rim, because this is smooth because it is actually a wall formed by the granulation tissue, and it's very clear, it is demarcated, and you can see the perilesional edema. So here, similarly, you can see if this patient had history of multiple sclerosis, stop treatment, and coming with a new lesion, new symptoms, and you take a T1 with GADA, you can see some enhancement, 2 rings. So rings, these rings are open towards the cortex. This is called open ring configuration. So this type of enhancement is seen with the tumefactory demyelination. You can see the restricted diffusion in this, but you can see the clearly open ring towards the cortex. So similarly, this is pilocytic astrocytoma, where you can have a cyst secreting portion and a partial enhancement of the wall. It's not fully, it's because of the high content of fluid. It is not completely enhancing. However, there is areas where there is tumor activity. Those areas will be showing enhancement. So this is a incomplete ring configuration with cystic lesion, pilocytic astrocytoma, and this is open ring, most common form where there is tumefactory demyelination. So when you get immunocompromised patient, for example, this is a patient with HIV and patient had multiple nodular lesions. So this is tuberculoma, but however, this can happen in immunocompetent patient as well. But if this type of thing lesion happen in a patient, this tuberculous abscess, biopsy proven, you can see the tuberculous abscess with the vessel wall showing infiltrates. So basically, this is tuberculous abscess where there could be systemic symptoms. Usually, it will happen with immunosuppressed patients, but these multiple tuberculomas can happen in immunocompetent patients as well. So simple approach would be, if you have immunosuppressed multiple lesion, tuberculoma is a possibility, fungal abscess. One thing is there, in immunocompromised patient or immunocompetent patients, those things which are spreading to the brain through the systemic circulation would be more common in the gray-white junction rather than in the cortex or very deep. So if the patient is having multiple ring enhancing lesions, it could be tuberculoma, fungal abscess, pyogenic abscess, because usually pyogenic abscess will be single, but there could be daughter abscess, and lymphoma. So immunosuppressed patient with single, we have to first consider toxoplasma, and then only we will consider other differentials, lymphoma and tuberculous abscess. So if there is an immunocompetent patient, deep white matter ring enhancing lesion should be glioblastoma multiforme. We have shown that, and lymphoma can involve the corpus callosum, because they are not exactly deep. They can happen in the white matter usually, especially between the hemispheres. So it will be callosum involved. So lymphoma can involve the corpus callosum. And if there are multiple, we have to consider endocarditis. Endocarditis, again, the abscess will be in the gray-white junction. So then we have to look for systemic symptoms like endocarditis. Patient will have, being unwell, fever, body ache, systemic symptoms, and then they will develop these brain symptoms. So that is endocarditis. And tuberculosis we know, and systemic fungal infection, propensity for fungal infection, and sometimes patient may be on immunosuppressive medications, or patient be having a malignancy. So whole body PET scan will help us to identify, uncover the hidden infections like a subdiaphragmatic abscess, a pelvic abscess, or other thing, and MR spectroscopy will give us an idea about the content. So this is the one question, like, so what is this ring enhancing lesion in an immunocompetent male with no systemic symptoms? So look at this lesion, what it could be. So this is deep. So what about the ring? Ring is very shaggy, very irregular, and there is perilesional edema, and it is quite deep. So what will be the differential? One differential would be mostly GBM, because it is deep. It is not causing any systemic symptom. It is deep in the white matter, and there is irregular enhancement. Suppose it is regular enhancement, and with this much of edema, it could be brain abscess. So same thing, glioblastoma multiforme, irregular, shaggy inside, thick variable enhancement, complex, sometimes multilocular, lot of vasogenic edema, variable rim on T2 weighted, and increased diffusion. Restricted diffusion will be there. So this is the necrosis inside the what. So this is brain abscess. You can see the regular one. You can see very deep. This is the glioblastoma multiforme, and this is pilocytic astrocytoma with incomplete ring. Here you can see the multiple sclerosis with the tumefactory demyelination. You can see the outside open ring. So now this is actually the GBM with the necrosis versus abscess. You can see the difference. The walls are smooth here, but it is irregular. You can see daughter lesions here, but only one lesion here. So neurocystic sarcosis is another differential. Neurocystic sarcosis is a very common differential outside Kerala because of the high prevalence of this lesion. And you can see there are several stages. Vesicular means you can see a small lesion and inside you can see small scolex-like thing, that will be vesicular. Then colloidovesicular would be a little bit more of a hyper intensity in the T2. And the granular nodular means there will be edema like this and there are multiple lesions. And nodular calcified lesion is the end stage lesion. So this is a 60-year-old lady with who is a diabetic with recent onset ataxia. So what is this differential diagnosis of this ring enhancing lesion? So this is a very common thing, especially in the diabetic with the history of TB or without TB. We can simply say this is a multiple loculated ring enhancing lesion. Usual differential is actually tuberculoma, multiple tubercular granuloma. So perfusion and spectroscopy can help in the ring enhancing lesion, like either perfusion could be the ASL perfusion or gadolinium perfusion. Like we can see different peaks like choline peak, NS or creatine peak or other amino acid peak. We'll come to that later. So tumefactive demyelination, I told you this is the ring enhancement. There is an outside open ring, so this is incomplete ring, very clear. So you can see in the MR spectroscopy, you can see the high choline creatine ratio, and it can mimic a tumor but you can see this is incomplete enhancement. So one important thing is there is no significant perilesional edema. There is no perilesional edema around the demyelination, not much. But in this case, there is some perilesional edema as well. So this is a tumefactive demyelination where you can see the choline peak, and also after treatment, you can see it has completely resolved with a steroid treatment. So in an HIV negative patients, multiple ring enhancing lesions in HIV negative patients, if the lesion size is small, less than 5 millimeter, 5 to 10 millimeter less than that size, you can take an X-ray chest. If X-ray chest abnormal, if the miliary shadow, it is tuberculoma. Lung cancer, like cannonballs, it could be metastasis. Hilar shadows, you should suspect sarcoidosis. And if there's pneumonia or other systemic infection, you have to suspect abscess. See, if the X-ray chest is normal, we have to go with CSF because these are multiple small lesions. You have to look for ELISA for neurocystic sarcosis positive. It is neurocystic sarcosis. VDRL, it is neurosyphilis. If there is TB meningitis picture with ADA positive, lymphocyte count, high protein, you have to suspect tuberculoma. And if there are fungal IFA or cryptococcal or other aspergillus positive, you have to think about fungal granuloma. If diagnosis is not established, you have to go for a biopsy, cytostatic biopsy. If there are multiple ring enhancing lesions in the HIV negative patients are large, you have to suspect abscess, metastasis, glioma, or tumefactive MS. We have told how to differentiate all these things. In HIV positive patients, mostly it is toxoplasma, so we give empirical therapy. We try to diagnose it by toxoplasma serology, and even if negative, we'll give toxoplasma treatment. We'll look for response, and if it is not responding to treatment, then we'll go for biopsy. It could be lymphoma, primary CNS lymphoma in HIV patients, or tuberculoma or fungal. So MR diffusion, MR perfusion, MR spectroscopy, all these things can be useful. Also PET scan, they allow us to know about the further features without doing biopsy. So cerebral abscess, it shows that hyperintense signal on diffusion weighted images and hypointense signal on ADC. So that is important to identify the restricted diffusion pattern. And pus is associated. Why? Because there is more cellularity and high viscosity inside the pus. So the hydrogen, the proton molecules are not moving. So that will be restricted diffusion. But in cystic brain tumors, we are not able to see the restricted diffusion. So perfusion, as you know, the secondary is the metastatic lesions and primary gliomas will have more perfusion. So that will help us to identify. Spectroscopy will have like choline peak in the tumor and the amino acid peak in the abscesses, lactate and succinate peak in the parasitic cyst, and lipid peak in the tuberculoma. So these different type of peaks in the spectroscopy will help us to identify the type of lesion. So tuberculoma, show lipid peak. That is a very important point. And in demyelinating disorder, we can see glutamate or glutamine peaks. So all these peaks in the spectroscopy may give us a clue So where you do brain biopsy for these patients. So I mean, we will try to avoid brain biopsy with the radiological approach and clinical approach, but however, sometimes it will be very difficult. Patient may not respond, but whenever there is a non-responsive lesions, we have to go for brain biopsy because it is well proved that brain biopsy is not that dangerous. Like the mortality of brain biopsy in large series from Mayo Clinic is not very high. It is very comparable. So the outcome can be much well improved by doing a brain biopsy. So biopsy of undiagnosed multiple ring enhancing lesion should preferably performed with a stereotacty with a minimal tissue injury. So this is well possible. So especially in HIV patients, the American Academy suggests to do ring biopsy for negative toxoplasma serology patients, because if it is negative for toxoplasma, it could be lymphoma, tuberculoma, or fungus, and we have to identify them and treat accordingly. So we'll carry on with certain rules of thumb. So if there is a nodular lesion, if there is not thick and nodular lesions favors neoplasm. So if there's an enhancement which is a nodular pattern, think about neoplasm. If there is thin regular enhancement in the ring, we have to think about abscess. If there's an incomplete ring with open towards a cortex, it favors demyelination. So if there is low T2 signals, it favors abscess, and restricted diffusion, usually GBM, demyelination, or an abscess. So if you look at the edema, extensive edema suggests abscess or neoplasm. So if there is extensive edema, there are two possibilities. One is the edema, one is the abscess, other is the neoplasm. And the neoplasm we can identify by perfusion when there is a high hyperperfusion of that area. So central fluid content, if there is a central fluid content and restricted diffusion, it is abscess. If no restricted diffusion, there is a tumor with a central necrotic content. Number of lesions, we have mentioned about number of lesions. So similar sized rounded lesions at gray white junction favors metastasis or abscesses. Irregular mass with adjacent secondary lesion suggest GVM with edema. Small lesions less than 2 cm with a thin wall, especially if other calcific foci are present, suggest neurocysticercosis. So in conclusion, multiple ring enhancing lesions are commonly encountered neuroimaging abnormality. Distinguishing between neoplastic and non-neoplastic etiology is extremely important for planning the treatment. Many features of the lesion as well as clinical presentation and patient demographics need to be taken together to help to narrow the differentials. Thank you.
Thank you, sir, for that wonderful eye-opening presentation. So we actually, I had a few doubts, sir. So how, if you want to differentiate neurocysticercosis and tuberculosis, many times us physicians come to this confusion when we see multiple ring enhancing lesions in the brain. Is this tuberculosis or is this neurocysticercosis, especially immunocompetent individuals? So how do we go about so differentiating that, and whether there's any role for Mantoux test, sir, in when we are suspecting a tuberculoma in the brain, sir?
Yeah, definitely yes. So, I mean, this is not a single test which is proving it unless you do biopsy. So this is actually corroborative evidence. Like if when the patient is having multiple, when some immunocompetent patient shows multiple tuberculomas, usually there will be evidence of systemic tuberculosis. But in case of immunosuppressed patient, it can have everything. But however, generally in immunosuppressed patient, neurocysticercosis will not be producing that much immune response. So the lesions may not be having multiple stages. Only calcified lesions may be seen. But it is important to do all the corroborative tests unless you do a biopsy. If you're taking decision without a biopsy or without a tissue diagnosis, means like if we have Mantoux test or a lymph node with in the neck with the TB positive or other ulcer positive and all, then it should be better. But if you are not taking any tissue, it will be better to do all the corroborative tests, because in many of the series when we in CMEs where Mayo people are involved, they also see the patient with, they think it is a tumor factor demyelination. They take the biopsy, it is a lymphoma. They think clinically or radiologically, they think it is a lymphoma. They take the biopsy, it's tumor factor demyelination. So we should be extremely careful while taking final decision. One of the thing is in case of neurosis cirrhosis and other thing, we can have a therapeutic trial. A therapeutic trial may be helpful, but however, especially in immunosuppressed patient, when there is no toxoplasma, no response to toxoplasma, then we have to. It is better to take biopsy. So, Mando test is, of course, it is useful, but immunosuppressed patients, depending upon their CD4 cell count and all, their Mando test may be or may not be positive. So, unless unlike immunocompetent and immunosuppressed patients, it is difficult to do without biopsy.
Sir, and any role for the empirical ETT, and follow-up MRIs like 3 months later, 6 months later, if we are starting on a patient with suspected tuberculosis, any role?
Yeah, absolutely. Absolutely. This is what we used to practice in real life, even though we would say biopsy many of the time. As I mentioned, the biopsy is actually not that much risky. Biopsy can be done and it will give us a lot of comfort and confidence to treat the patient. But however, most of the time, the family and the patient may not be willing for a biopsy. That is one of the problems. So this biopsy is not a stereotypic biopsy of the mass will settle the issue. But many of the time, family will be afraid to undergo GA and do a stereotactic biopsy. So, in fact, we have very good facility to do robotic biopsy where the damage will be much less and the side effects are much less. But empirical treatment, of course, empirical treatment is recommended by American Academy for an immunosuppressed patient for any ring enhancing lesion, as considering it as a toxoplasma. So you give toxoplasma treatment and look at the response. Similarly, in the first scan, the case scenario I have discussed in the talk, this patient had a subacute infarct with hemorrhagic transformation, and there is a ring enhancing lesion. So in those situations, actually, since the patient is improving, we could have taken another scan after 6 weeks. So usually 4 to 6 weeks, we will take another scan, because most of the time we would be understanding the lesions which are going to go for an impending herniation. For example, a glioma. So if you see a glioblastoma multiforme, there will be rampant edema and midline shift, and it will look like it is so tight in the brain. So we cannot wait for any more time. But in low-grade glioma or other things, we can actually wait for 4 to 6 weeks. You take another MRI with contrast or another CT with contrast. You can see the lesion size increasing or the overall midline shift is increasing. Then definitely we would go for excision biopsy or stereotactic biopsy. So I think there is a definite role for taking appropriate therapeutic step as well as repeating the imaging. This should be a part of our practice, and this is actually customized. For example, you see the first CT or MRI, you see the lesion that's very aggressive, lot of edema, and there is midline shift. You would be hesitant to go for conservative treatment unless you have some other corroborative evidence. For example, you have a patient with a large lesion with a lot of edema, slight midline compression, and you got endocarditis, or you got a pelvic abscess, you got some subdiaphragmatic abscess or a liver disease or a Klebsiella pneumonia, then okay, you think it is a brain abscess. Then you would give a course of antibiotic therapy and see, like maybe within a week, you take another scan with anti-edema measures and antibiotic therapy. But in other situations, it will be, it is highly customized for the patient. So it is in a given context, you would be giving the appropriate step and the treatment. I think we cannot generalize. It is highly physician dependent and depending upon the clinical context. So, but however, generally you would be able to understand whether this lesion is really bad. Like a large glioma with a lot of edema, impending herniation, you straight away go for surgical decompression and biopsy. And if there are multiple small lesions and they are not very dangerous, patient is having minimal headache and all, you may try, you give treatment and then you wait. You give steroids and albendazole, or you give AKT for 2 weeks with steroids and see. But when it is not responding, it could be a fungal one like that. But we would somehow get some clues during the whole clinical picture. So I think it is highly physician dependent, but we'll follow these general guidelines.
Okay, so thank you very much, sir, for this joining this session and enlightening us. So now, since you're running short of time, we'll quickly move on to the next session. Thank you, sir. Thank you, sir. Over to you, Ra. Thank you.
Thank you, Vivek sir, for that excellent session. I'm sure everyone who was listening must have found that very useful. Next up, we have Dr. Priya Nair. She's a proud alumnus of Amrita Institute of Medical Sciences, having completed a DM in gastroenterology and fellowship in therapeutic endoscopy from Amrita Institute of Medical Sciences. She is a skilled clinician and has published several research publications in both national and international journals. She's currently working as an associate professor in the Department of Gastroenterology in Amrita Institute of Medical Sciences. Over to you, ma'am.
Good evening, everyone. At the outset, I would like to express my gratitude to all the organizers of this Amrita Medicine update. It's an honor to be able to take part in an internal medicine CME online, and especially amidst this time of COVID, these kind of CMEs go a long way in keeping us all up to date, as well as help us to feel connected amidst this time of external chaos. So I had been asked to discuss the topic of fever or pyrexia of unknown origin and the role of endoscopic ultrasound. So I'll get into the topic right away. So I'd like to start with a case that I had actually worked up when I was doing my therapeutic endoscopy or EUS fellowship. There was a 20-year-old boy that had come. He had had around 8 to 9 months of fever, a daily evening rise. Highest was about 100 to 105 degrees Fahrenheit. And he didn't really have any other symptoms. He had been admitted multiple times just for a battery of tests. And all tests, he'd even done a bone marrow biopsy because his father had passed away of leukemia. So his family was quite worried about these daily fevers. So they had even done a bone marrow biopsy, but everything was normal. So finally, when the fever started to become a little bit more frequent, he had few spikes in a day. He was brought here. At initial examination, there was really nothing. His physical examination was unremarkable, no lymph nodes, nothing. All his routine labs were done, and they were all normal, except that his C-reactive protein was 18. So as part of his evaluation for fever, he had a CT abdomen as well as chest repeated here. And one of the findings that was there, the only abnormal finding in the CT was that there was a 2 into 1.5 centimeter isodense lesion. It was actually hardly visible on CT. The radiologists were not sure whether it was a peripancreatic lymph node or maybe even a pancreatic mass or some kind of a gastric tumor and submucosal tumor of the gastric or a duodenal wall. They were not sure exactly what it is because it was very isodense. There were no other lymph nodes noted, no other collections, masses. Otherwise, the CT chest was normal and the CT abdomen was unremarkable except for the small little lesion. So he had all his tumor markers sent, everything came as normal. And he was then referred to gastromedicine for an EUS study. So on EUS, we found that unlike the CT, which showed a very isodense lesion, on CT, there was a very well-defined hypoechoic homogeneous mass, which looked more like a lymph node than a mass that was arising from the pancreas. And we could quite easily access it because all the structures in the retroperitoneum are very easily accessed through the through endoscopic ultrasound. And we did an FNA as well as an FNB or a fine needle biopsy of the mass. And this is basically what was seen. You can see some lymphocytes, some inflammatory nucleus and neutrophil, and it is all seen scattered amidst a lot of fibrous tissue. Samples had also simultaneously been sent for TB evaluation, cultures, cell block, all kinds of testing was done on the tissue, and everything came as normal, including IHCs that were sent. And finally, the diagnosis given by the pathologist was inflammatory myofibroblastic pseudotumor of the lymph node. This is basically a very rare etiology, a very rare tumor, and it is also not very well understood. Sometimes it comes in the background of autoimmune diseases. Sometimes, more often than not, it is just a completely independent thing, and its origin or its etiology is very poorly understood. So we'll get into the topic, and then at the end we'll discuss what actually happened with the patient. But I'd like to start with just a very brief discussion of fever of unknown origin to begin with, PUO. It's actually quite silly for gastroenterologists to be discussing PUO with internists. But that being said, since there isn't any other discussion on PUO, we'll just briefly go through some of the points. So as we all know, the definition for PUO was actually written in stone as long ago as 1961, and basically the definition hasn't really changed. It was derived by Petersdorf and Beeson, and essentially there are three aspects to it. You need to have a fever higher than 38.3 degrees centigrade on several occasions. The duration of fever should be for at least 3 weeks. And there should be an uncertain diagnosis even after 1 week of study in the hospital. So these are and if you look at through the years, this really has never changed. So this particular scenario has continued to baffle physicians from the beginning of the century. When we look at various studies done on fever under evaluation, you see that the first publications on PUO was as early as the 1910, 1930, 1913. And there has been multiple studies through the decades, the largest study being more recent, which was actually done using patients from Asia, Europe, as well as the Middle East. It was the largest study published by Fusco, and it had more than 3,000 patients involved in the study. And if you look at all of these different studies, essentially you'll find that the same set of conditions formed the eventual cause or the diagnosis of all of these patients with fever under evaluation. And you'll find that the etiology essentially breaks down into infections, malignancies, or systemic rheumatic diseases or autoimmune diseases, including vasculitis, rheumatoid arthritis, SLE, polyneuritis arthritis nodosa, all those set of autoimmune diseases. So between these three, infection, malignancies, and autoimmune diseases, that essentially covers a large amount of the final etiology or the final diagnosis for patients with fever of unknown origin. And if you look at, so here were the breakdowns of the causes of PUO in all those different studies, and you'll see that infections form an important part, including most important mycobacterial infections. Unlike areas like India, where we are lucky enough to have our internal medicine professors, as well as all doctors have, alarm bells ring as soon as you have a patient coming in with any fever, and tuberculosis is always very high up in the list of differentials. But unlike areas like ours, in many parts of the world, TB is considered to be a very rare disease, and hence you can see both in Asian studies as well as studies abroad, TB forms a very large number of patients that present as fever of unknown origin. Some of the other infections, including endocarditis, abdominal abscesses, and then you have all your malignancies like lymphomas, solid tumors, and other autoimmune conditions like lupus, rheumatoid arthritis, giant cell arthritis, and rheumatic fever as well. So here is just, I took the long list of differentials that were given in UpToDate. And if you look at a lot of them, you find, see, they've put in bold some of the very important causes of PUO. And you'll see that abdominal abscesses, tuberculosis, lymphoma, GI malignancies like hepatocellular carcinoma, neuroendocrine tumors, liver metastasis, sarcoidosis. A lot of these very important or more common causes of fever of unknown origin arise from the thoracic cavity as well as the abdomen. And this has always been a big challenge for physicians from reports of PUO all the way in the early 1900s. And this is essentially because the thoracic cage as well as abdomen were always considered as like secret hidden areas, in the sense that it couldn't be accessed. Even physical examination was very difficult. We have our traditional methods of palpation, percussion, but that still cannot give you a definitive cause for fever under evaluation. And even after the onset of cross-sectional imaging like CT and MR imaging, still there was a big question of how do you access the tissue? How do you get the tissue from the retroperitoneum, from the thoracic cage? And until the onset of endoscopic, either EUS or even EBUS, endobronchial, until these modalities came into vogue, even the CT guided biopsies all had their own set of limitations. See, if you look at through the history, you can see that the incidence of infections as a cause of PUO has gradually come down. Malignancies as a cause of PUO has gradually come down. And all of them essentially are showing a downward trend except for one, and that is this category of no diagnosis. And I put this slide up because I think it's very important to note that as technology increases, your infections, everything else may become easier to diagnose, but this particular entity of fever of unknown origin, that's always going to be there, because unfortunately technology will always have its limitations. And as you can see through time, the cause of fever of unknown origin has yielded no diagnosis more and more as your technology has improved. And it's not necessarily because technology is failing, but it's just that we won't ever necessarily be able to catch up with the changes in disease over time. So we briefly spoke about this, but what are the challenges? Essentially, one of the many challenges involved is tissue sampling, because considering that a significant number of the diagnosis of PUO lies in malignancy, infection, or autoimmune disease, you basically need to confirm that with tissue. So reaching the areas of difficulty, most importantly being intra-abdominal as well as mediastinum, that challenge is significantly met by EUS and EBUS. Even CT-guided FNA techniques have their limitation because you cannot cross bowel. That's the biggest problem. You cannot cross any gas-filled or air-filled areas. So going through the lungs, accessibility going through the bowel, all that becomes limited when you're doing a CT or MR guided FNA technique. So here's where you have the role of EUS. Endoscopic ultrasound, it's a simple concept. Endoscopy had been discovered as early as the 1920s. And by putting an ultrasound probe at the end of the scope, essentially you're giving it a new power or a new modality of diagnosis with the same scope. So it is one of the easiest methods to access mediastinal and retroperitoneal masses or lymph node enlargement. And the advantage, especially of EUS, is that it's a very simple outpatient procedure that now over time has become very safe. It has a very high safety profile. There are disadvantages, that being said, to EUS, though they are essentially that it is still quite an expensive test. It also needs to be done under anesthesia because it takes a good 1 hour to 1.5 hours to complete the test, this is also because it is done along with something called ROSE, or rapid on-site evaluation, which we'll discuss later on. But nobody can really sit with an endoscope in their mouth for 1.5 hours. So it has to be done under anesthesia. It need not be done under general anesthesia where the patient needs to be intubated, but there needs to be deep sedation. Also, patients that have a short neck or obstructive sleep apnea, there can be some challenges. But that being said, these are all challenges that can be very easily taken care of with some amount of tender love and care and proper training of scope usage as well as techniques of EUS. So a few basics on EUS. Originally, when EUS had come into vogue, it was a radial transducer. That is, there was 360 degrees vision all around the actual EUS transducer. And this is essentially like a CT. So you have CT cuts or axial cuts of the chest or the abdomen, and it made it very easy for doctors to be able to compare the CT films or CT images with the EUS images. It helped to compare it on a one-to-one basis, so you could actually find things. It's interesting to note that a lot of masses that need not be or may not be visible on CT are often visible on ultrasound, even if it's just transabdominal ultrasound. But and there also are a subset of masses or collections that may not be very well seen on an ultrasound, but that are very well seen on a CT. So it does go both ways. So what the main disadvantage of this radial EUS was that there is no way to do if the transducer is 360 degrees, you cannot actually, the needle would come out of the tip of it and you would not be able to see the passage of the needle. So it would still be a blind biopsy. Hence, radial EUS was very quickly replaced by linear EUS, where the transducer was only on one side. It was a 120 degree, some are 145 degree of visibility or penetration of the ultrasound waves. And as you see here, there's a working channel. And through this working channel, you can introduce catheters, you can introduce needles, mainly FNA needles or fine needle aspiration or biopsy needles. And as you can see here, the needle actually passes within the line of vision. And because of that, you have real-time biopsy, and it's a much safer procedure because you can actually real-time look for vessels, vasculature, reduce the chances of bleeding while taking a biopsy. So it's targeted biopsy essentially. So here are some examples. As you can see here, both of these are radial ultrasounds because they have 360 degree vision. Here you have of the mediastinum. So you can see both of these are of the mediastinum. So you have the aorta and the spine. And here you can see multiple matted nodes. This is a case of tuberculosis. Here's another patient where you have, this is the arch of the aorta. Here you have one thing to remember, any of you who may have done ultrasound imaging, you'll know that air is a big problem. Anytime there's air, you cannot see an entire wedge of vision is lost. Everything behind the air pocket or air shadow is completely lost. So the esophagus inherently has air because the gastrointestinal tract has gas always. So one important aspect of EUS, as you might have seen here, is you need to obliterate all space for air. So there's a balloon at the end of the EUS probe. This balloon is inflated to fill the entire esophageal lumen, and that helps to prevent any air from coming between the transducer and the tissue and gives us this 360 degrees. So this esophagus that they're pointing to is actually the water within the balloon of the scope. This is the scope. And you can see here there is a mediastinal mass. Even though it is not commonly done, actually you can pass needles even through vessels as large as the aorta, although we are always afraid to do it as an endoscopist, but there isn't really any major reason why you should not reach a mass unless there's some other better way to diagnose it. So one of the most important things when it comes to EUS of the mediastinum is sampling lymph nodes. So when it comes to sampling lymph nodes in the mediastinum, we have two modalities, as I mentioned before. You have the endoscopic ultrasound and you also have the endobronchial ultrasound. So it depends on where the nodes are, and you have to choose nodes or even mass or collection or whatever it is that you need to sample. You need to decide which is the best modality based on the location. So we all know the various stations of the nodes in the mediastinum range from station 1 all the way to station 14. So here you can see that the central stations, as well as the stations just below the carina, subcarinal nodes, all of those stations are accessible by EUS. Whereas the more peripheral they go, especially into the lungs, like all this 10, 11, 12, 13, 14, as well as pulmonary masses, those have to be sampled by the EBUS alone. So this is the usual chart we study to remember when to use EUS versus EBUS. So you can see that 2, 4, 7, these can be sampled by either EBUS or EUS. Then you come to 8, 9, as well as all the intra-abdominal, hepatic, adrenal gland, all those masses or nodes, you need to use the EUS, versus all the inner groups of lymph nodes all the way from 10 to 14, those require EBUS alone. So here's some more images that show you. So unlike the other one, initially we looked at the radial scopes where you have 360 degrees visualization, but you cannot sample anything with that. That's more for diagnosis. Here you have the linear EUS, and you can see these are matted lymph nodes in the mediastinum. This is the pulmonary artery. This is the left atrium. Here again, you can see between the pulmonary artery and left atrium, you have the node sitting there and under visualization. So you can watch and make sure, obviously you're in a very precarious area. You cannot overshoot the needle, which is why these needles have a lot of safety precautions, a lot of So there are many tests that can actually be done with the FNA and FNB samples. Originally, it was only cytology, and you send these cells in for centrifuging, and it becomes a little cell block, which they look at under the microscope. So that was all that could be done initially. But that has now changed with the advancement of technology and the advancement of the needle types. Now we can check, we actually can get core biopsy pieces. You can do immunohistochemistry on them. Also, we have all the infectious panels that we can send, including cultures, mycobacterial, bacterial, as well as fungal, gene expert, AFB smears, and cyst, aspiration of cyst or aspiration of pus can all be done using these EUS, FNA, or FNB needles. And the most common diagnosis that we get from these, especially in the chest, are TB, fungal infections, bacteria, and certain other bacterial infections. Obviously, Brucella and all are rarer. That being said, we have had quite a few cases of them here that we have diagnosed. Then your malignancies, including solid organ metastasis, lymphoma, as well as neuroendocrine tumors, and inflammatory etiologies, including sarcoidosis. There's one thing to note: there are very few absolute contraindications for EUS FNA, and one of them is actually mediastinal cysts, because mediastinal cysts usually have a high pressure within them. And no matter how small a gauge needle you use, there's two issues: rupture of the cyst as well as introducing infection into the cyst. And both of these can lead to life-threatening mediastinitis. And we all know that draining the mediastinal collections are very difficult to do. Hence, mediastinal cysts are one thing that just cannot be touched either by EUS or EBUS. There's a one of the advantages, another advantage of EUS is a concept of ROSE, or rapid on-site evaluation, which is actually the standard of care internationally. The pathologist or the cytologist actually comes for each and every procedure, and every time we remove a sample, we smear it immediately on site, and they check it under the microscope, and they have to confirm that we have adequate sample for them to make a diagnosis. And the reason why this is done is manifold. Number one is it is quite an invasive procedure, even though it is just a biopsy. You're doing it under some form of sedation. You don't want the patient to have to undergo this multiple times. So you need to make sure that at this particular sedation, you keep on taking samples until you ensure that the pathologist can give you a diagnosis. Also, there may be multiple different nodes, multiple masses, and you can also sample different masses and find out real time which mass may give the most sample, the most adequate tissue sample. Some masses or some nodes may be mostly necrotic and you cannot make a diagnosis off of them, versus other nodes that have a better solid component can actually give them more cells to read off of. So these are all the advantages of having rapid on-site evaluation, and it's essentially the gold standard internationally. So this is a sample of on-site staining, and here you can see there's an ill-formed granuloma, and this was a patient that had a tuberculosis. So going deeper now from the thoracic cage, you're actually entering into the abdomen, and the EUS is best for retroperitoneal lesions or nodes, all the peripancreatic, periportal, pancreatic masses, submucosal masses in the small bowel as well as the stomach, adrenal masses, masses around the kidney, collections around the kidney. Even like last week, we had a patient that had 6 months of abdominal pain and 2 months of evening rise of temperature, and everything was normal except that there were 2 lymph nodes surrounding one of the arteries at the greater curvature of the stomach. These were small nodes. They were only 1.2 centimeter in size. But when we sampled them, the diagnosis came as tuberculosis, in spite of everything, including the manto being negative. So there are lots of areas that you can actually reach with the EUS. You can even do rectal EUS and pelvic masses, pelvic nodes, pelvic collections. This is another whole area which has developed a little later and is still being developed, but that's another avenue that we can look at with endoscopic ultrasound. So here's an example. Here you can see this is the pancreas with the pancreatic duct being a little prominent and dilated. Here's the liver, and this is a whole lymph node group that is seen inside the ligaments around the liver. Here's another, this is the liver up here, up top, and you can see a periportal, well-defined shorty lymph node. This is another patient that came with abdominal pain, and this is not a fever under evaluation patient, but it's just to show some examples of EUS FNA. Here's the pancreas, which looks normal. Suddenly there's a small discrete mass, and then the pancreatic duct proximal to the mass is huge and dilated, and that turned out to be a neuroendocrine tumor, insulinoma actually. This was a patient that had come with fever under evaluation, also had constitutional symptoms of weight loss and loss of appetite, but no, the only thing that was seen was this 8 millimeter mass in the liver, which initially was thought to be a dysplastic nodule, and an FNA was done, and that showed adeno-CA, and IHC showed that it was of pancreatic origin, even though we could never find any pancreatic primary. So there are so many different types of scenarios where the EUS can potentially help us find a diagnosis. So I just wanted to put up this slide because initially, you know, like any of your hypodermic needles, the FNA needle also was just a very simple needle. And because of that, it could only really help in aspiration, and we had to apply suction to the other end of the needle, and you'd get a lot of blood and the sample would be very diluted. And the yield, tissue yield from EUS FNA used to be around 20 to 30%. And the infections, that became even harder to diagnose. But with time, there have been all kinds of modifications and updations of the needle. They have beveled, reverse bevel, forward bevel, claw-shaped needles, otherwise known as Francine needles. They have bevels on the outside as well as the inside of them. There are fork-tip needles, and all these needles have essentially helped in agitating the tissue around the area, grabbing it into the needle, increasing. So these beveled needles actually give you proper cores of tissue, which have actually made fine needle biopsy much more of a reality and much more of a practicality than actual fine needle aspiration. So coming to what happened to our patient, the 20-year-old boy that had come with fever. So we still continued to look for all other etiologies of lymphadenopathy. Cultures were done, PET scan was done, all kinds of things were done, and finally no other cause was identified. And without any other specific treatment plan in mind, we started him on a short course of steroids. Your usual, 40, 30, 20, 10 tapering dose of prednisone. And his fever subsided within 2 to 3 weeks. And we did a repeat CT after 2 months, which essentially that node was still present, but it was just a normal sized, less than 1 centimeter in size node. And he has been asymptomatic. It's been 4 years now, and he still does not have any symptoms. So who knows what really or why that actually happened, but that was just one of the multiple interesting cases we've had. So essentially the points that we need to take home from this is that areas of the body which were initially considered hidden from the biopsy needle are no longer necessarily hidden with the onset of EUS and EBUS. Tissue acquisition has significantly improved over the past 10 years, not only because of improved EUS technology, but also because of significant improvements in the needles. And EUS screening of the liver and pancreas can often give you information that the CT or MR may not be able to give you. So in cases where you're really stuck and there's no other cause that can be identified, it can be one extra value add-on that might be able to aid in the diagnosis of patients with pyrexia of unknown origin. So with that, I come to the end of the presentation. Thank you all for your patient listening. Am I audible? I'm not hearing you, Subhash. It's muted, I think. Mm-mm.
Hello? Sorry. Is it
Yeah, I
audible
can
now?
hear you now. I can hear you.
Okay,
Yes,
sorry. Yeah,
yeah.
actually, this sort of we had a question about like what are the common complications we encounter in EUS? Are there any serious complications when we do EUS, or is it like generally a safe procedure?
It's safe in general, but I think the most important complication is a hemorrhage. You can, if you pass the needle through vessels without properly using the Doppler part of the ultrasound procedure, then you can potentially have bleeding. There are certain other complications related to the scope. You can accidentally perforate the lumen. It has a very long, rigid end of the scope. The ultrasound part is not flexible, unlike the rest of the scope. These are all rare complications. Also, like when you biopsy tumors, there can be theoretical seeding of the tract. So especially when we biopsy tumors of the pancreas, you try to always biopsy through a part of the bowel that will anyway be removed during surgery. So some complications, the most important one is bleeding, but it is relatively safe in general. Yeah.
Okay, and this what are the common diagnoses you come across? Like usually when you go for this US and FUO, what are the varied diagnoses you come across?
I think it's in India, we mainly see tuberculosis. The weirdest manifestations of tuberculosis, obscure single node tuberculosis. But then we've had histoplasma, we've had abdominal nodes showing aspergillosis. Then we've had, like I mentioned, one of the case, inflammatory pseudotumors. We have a lot of these neuroendocrine tumors that actually present as fever with some big bowel symptoms. And then sarcoidosis is another one that we have seen in the past quite a bit.
There was one question actually.
Brucella also we have
Brucella,
had a
okay.
few cases.
Okay. There was one more question. Like some physicians have a doubt. Like, is this actually, can we do biopsy through the US, or is it only FNAC that can be done? Like that's a doubt in many people's
So
mind.
there's two types of needles. You can do FNA, which is use an FNA needle, which is a fine needle aspiration. So that's for pure cytology. Then you have an FNB needle, which is a fine needle biopsy. That I had shown some different needles. So there are needles that have these beveled tips where you can actually get a core of tissue. The same kind of core biopsy needles that you use for liver biopsies. It's pretty much the same. So you can get biopsy cores, but forceps biopsy you cannot use with a EUS needle. It's obviously because it's a needle, you're only using, you can only get what you can get from a needle core. That's it.
Okay. Anyway, thank you very much, Priya, for joining us in this session.
Thank you
I
so
think
much.
this endoscopic ultrasound is a very important modality, especially some patients of ours with FO, even they're not willing for empirical ATT and all. So
Yes.
the tissue diagnosis helps us a lot, in convincing the patients that actually ATT is required, that it is TB, especially when there are only mediastinal nodes and those sorts of things.
Yes.
So thank you very much. Thank you.
Yes. Thank you so much. Thank you.
Moving on to the next session.
Thank you, Dr. Priya. That is a very valuable and informative session. Next up, on the mic, we have Dr. Akash Thomas. He is currently a professor in the Department of Medicine, AIMS Kochi. He is an astute diagnostician who is known for his excellent commitment to providing patient care. Over to you, sir.
Hello everyone. Over the next few minutes, I'll be giving you an overview of non-alcoholic fatty liver disease and approach to non-alcoholic fatty liver disease based on the various consensus statements and guidelines currently available. The prevalence of non-alcoholic fatty liver disease is increasing among adults all over the world. Unfortunately, this trend is also seen among children and adolescents. This is basically because of the changes in the lifestyle and the increased incidence of childhood obesity. In fact, it has become one of the most common cause of chronic liver disease in Western countries. It has become one of the primary indication for liver transplant in many of the countries. In our country, the prevalence in our country is 9% to 32% of the general population. Considering the gravity of the situation, the government of India has included it under our flagship program for non-communicable diseases, that is the National Prevention Program for Control of Cancer, Diabetes, Cardiovascular Disease and Stroke. There is a strong association between fatty liver disease and metabolic syndrome. In fact, the severity of NAFLD corresponds to the severity of metabolic syndrome. It is considered as a hepatic manifestation of metabolic syndrome. There has been a movement to change the terminology from NAFLD to MAFLD, that is metabolic dysfunction associated fatty liver disease. All of us know about the hepatic outcomes of NAFLD, but what we need to stress upon is the independently associated risk, that is NAFLD patients have an increased risk of cardiovascular morbidity and mortality, especially patients with NASH. There is a higher risk of developing diabetes mellitus in patients with NAFLD. The various terminologies by which it was going on was pseudo-alcoholic hepatitis, alcohol-like hepatitis, fatty liver hepatitis, steatohepatitis, and diabetic hepatitis. It is a rapidly evolving field with multiple guidelines and consensus statements. Now, the spectrum of disorders ranges from non-alcoholic fatty liver to non-alcoholic steatohepatitis, which can progress to cirrhosis and hepatocellular carcinoma. All guidelines have agreed on the fact that it is characterized by hepatic steatosis in the absence of secondary causes and the absence of excess alcohol consumption. What they disagree upon is the definition of excess alcohol consumption. Now, the Indian guidelines and the Asia Pacific guidelines are the most conservative in this, that they have put a cutoff rate of 20 grams per day for both males and females. A 10 gram of alcohol will correspond to approximately 30 ml of distilled spirits, example whiskey, or 100 ml of wine, or 240 ml of beer. Now, what is the difference between NAFL and NASH? NAFL, that is non-alcoholic fatty liver, is characterized by steatosis but without inflammation, while NASH is characterized by steatosis with inflammation and cell injury resulting in apoptosis, which can progress to fibrosis and cirrhosis. The established risk factors for NAFLD are central obesity or truncal obesity, insulin resistance, that is type 2 diabetes, dyslipidemia, and metabolic syndrome. There is an association, independent of obesity. It has been found that NAFLD patients have an association with PCOD, hypothyroidism, obstructive sleep apnea, hypopituitarism, and hypogonadism. Now, the pathogenesis is not very clear, but the accepted hypothesis is the main thing is insulin resistance. Now, along with this, there is a second hypothesis, that is insulin resistance starts off the steatosis, but a second hit in the form of an oxidative injury is required for it to progress into hepatitis, that is inflammation and fibrosis. Some of the other factors that have been implicated in the pathogenesis are the hepatic iron, deficiency of leptin and adiponectin, in the alteration of the intestinal bacterial flora, bile acids, incretins, dietary cholesterol, and obstructive sleep apnea. Coming to the clinical features, majority of the time, majority of patients are asymptomatic. NASH patients can be asymptomatic. Also, they can have vague symptoms like fatigue. They can have vague right abdominal discomfort. Usually, NASH is detected in the age group of 40 to 50 years. Some of these patients can have hepatomegaly. Once they develop cirrhosis, they're going to have the common features of a chronic liver disease. Usually, it is in the age group of 50 to 60 years. What are the liver function LFT abnormalities that we can see in a patient with NAFLD? One is you can have a normal liver function pattern. The second pattern that you can have is a mild to moderate degree elevation in the transaminases, that is AST and ALT. But the degree of AST and ALT elevation does not correspond to the inflammation or injury. The usual thing is the AST, unlike an alcoholic liver disease where the AST-ALT ratio is more than 1, in patients with NASH, the AST-ALT ratio will be less than 1. One thing that we have to consider is, as the disease progresses and the patient goes into hepatic fibrosis, the ALT levels will decrease, and later stages it can be that the AST is more than the ALT. Alkaline phosphatase can be elevated up to 2 to 3 times normal. There can be mild elevation in ferritin, transferrin saturation, GET, and even a low titer of autoimmune antibodies in the form of the common ones are anti-nuclear antibodies and anti-Smith antibodies can be present in the absence of an autoimmune disease. Now, if you find that the ferritin is more than 1.5 times the upper limit of normal, it is usually associated with a higher NAFLD activity score and thus NASH and with hepatic fibrosis. It is a clue. In patients with cirrhosis, there is not going to be any difference in the LFT abnormality when you compare with the other etiologies of cirrhosis. Imaging. Imaging can detect non-alcoholic fatty liver disease, but it cannot differentiate between a non-alcoholic fatty liver and NASH. The first modality of imaging is ultrasound. Ultrasound will show a hyperechoic texture or a bright liver because of the diffuse fatty infiltration. It has got a sensitivity of 85% and 95% specificity for detecting when the patient has at least 20 to 30% steatosis. Less than that, the preferable imaging would be CT or an MRI, MR spectroscopy to be exact, for detection of hepatic steatosis. But these are not commonly used because of their availability, expensive, and the time required for these tests to be done. In the ultrasound itself, we have the ultrasound-based transient elastography, which has been routinely used to detect fibrosis based on the liver stiffness. It is also being developed to degrade the hepatic steatosis, but additional data are required as per the various guidelines that are available. Now, coming to steatosis, all guidelines do not advise or recommend any specific testing or scores for steatosis, while the Asia Pacific and the European guidelines, they recommend the usage of fatty liver index score and the NAFLD fat liver score for the presence and not for grading or the severity. The fatty liver index is based on the triglyceride level, body mass index, waist circumference, and GGT, while the NAFLD liver fat score is based on the presence or absence of metabolic syndrome, diabetes, fasting serum insulin, and aminotransferase levels. Coming to the fibrosis assessment, Asia Pacific guidelines do not give any specific recommendation regarding any specific tests or algorithms for the assessment of fibrosis, while the European guidelines and the AASLD guidelines recommend the usage of the fatty liver score, the fatty fibrosis score, FIB4 score, and the usage of elastography. The American guidelines do not recommend the sequence or the algorithms, while European guidelines prefer to start off with the fatty liver, fibrosis score and the FIB4 score first, and then progress on to requirement of elastography and where required liver biopsy. What are the risk factors which are associated with advanced fibrosis in a patient with NAFLD? There are two patient-related risk factors and disease-related risk factors. The patient-related risk factors are: one, use of alcohol, a BMI more than 28, patients who have diabetes mellitus, and older age, that is more than or equal to 50 years, have an increased risk associated with advanced fibrosis. While the disease-related risk factors include histological evidence of inflammation, ballooning degeneration, Mallory-Hyland, or fibrosis on biopsy. While the lab test is elevated serum aminotransferases more than 2.5 times the upper limit of normal, that is AST and ALT. Coming to liver biopsy is considered as of now the gold standard for diagnosis of NAFLD. It is the only method that is currently available to differentiate fatty liver from steatohepatitis. Now, liver biopsy is indicated only in selected individuals. All guidelines, different guidelines have different. The Asian guidelines say it's only indicated if there is a presence or you're suspecting a severe presence or severity of a coexisting liver disease cannot be excluded, or you want to assess the fibrosis when non-invasive testing is inconclusive. While the American European guidelines advise it, recommend it for if you're having a suspicion of advanced fibrosis or to confirm the findings and for prognostic implications and management. Now, the practical implication of this American and European guidelines is: one, we do not have a specific treatment for the management of NAFLD. Secondly, most of these patients have associated comorbidities, and being an invasive procedure, many times it is risky to do this procedure. So to summarize liver biopsy, only if you have an uncertain diagnosis or you're suspecting NAFLD related advanced liver disease are there indications for doing liver biopsy, which is an invasive procedure. Coming to the diagnosis, all guidelines agree on the same diagnostic, that is demonstration of hepatic steatosis by imaging or biopsy. 2, exclusion of significant alcohol consumption, exclusion of other causes of hepatic steatosis, and absence of coexisting chronic liver disease. In other words, this is demonstration of hepatic steatosis and exclusion of other conditions. That means it is basically a diagnosis of exclusion. So when you have a suspected NAFLD, what are the other common disorders that we should rule out? One is alcoholic liver disease, hepatitis B, and hepatitis C. In the right context, in young individuals, Wilson's disease, hemochromatosis, thyroid disorders. If you are suspecting an autoimmune etiology, you think about workup for autoimmune hepatitis. When required, based on the history, drugs should be suspected. Starvation can produce altered liver function. In specific context, that is, you can consider acute fatty liver of pregnancy or HELP syndrome. Now, what about screening for NAFLD? All the guidelines recommend that screening for general population is not recommended. Now, specifically for high-risk population, The American guidelines, AASLD guidelines, do not recommend screening even in high risk groups, but they advise to keep them under observation. While the Asia Pacific and the European guidelines specifically mention patients with obesity or diabetes, and the European, in addition to that, have mentioned metabolic syndrome or patients who have persistent abnormal liver functions, liver enzymes to be screened for NAFL. Now let's talk about the treatment options available for patients with NAFLD. You have two treatment options available. One is lifestyle intervention and another one is pharmacological treatment. We'll start off with the lifestyle intervention. All guidelines agree on one thing, that diet, exercise, and weight loss are the lifestyle interventions that should be implemented in patients with NAFLD. Now, out of this, weight loss is your keystone for improving the histological features of NASH and reversing the disease. Now, weight loss should ideally be gradual. Rapid weight loss is not advised at all. It should be a gradual weight loss. A targeted weight loss of 7 to 10% of the body weight over 6 to 7 months would be an ideal way of reducing weight. How would you achieve that? It should be ideally with a combination of diet and moderate intensity exercise. Now, what is the type of physical exercise it should be a combination of aerobic exercise and resistance training. Now, the resistance training is important, especially in our context. A combination of resistance training is important in our context, especially when you consider that we have patients with lean NAFLD, which I will be coming to earlier, which resistance training will improve the muscle mass. What is the diet that is recommended? Most guidelines do not give any specific diet, but there is an agreement that a Mediterranean diet would be the most effective in reducing weight loss and bringing about the beneficial effects on the associated cardiometabolic risk factors, which are usually associated with NAFLD, like hypertension, diabetes, dyslipidemia, truncal obesity. For those who are obese, a daily calorie deficit of 500 to 1000 would be ideal. Like I mentioned earlier, the Asia Pacific and the American guidelines do not recommend any specific diet or exercise regimen, while the European guidelines specifically mention ideally it would be a Mediterranean diet with avoidance of processed foods and added fructose. Now, what about alcohol consumption? No guidelines are giving any recommendation, but the consensus is that once a patient has developed NAFLD, it would be ideal to avoid alcohol consumption of any type or any amount in patients with NAFLD. Coming to the pharmacological intervention, I would like to start by saying there is no approved drugs as of now to treat NAFLD and NASH, though a lot of research is going on. As of now, there is no approved drugs to treat NAFLD or NASH. So what is the treatment aimed at? The treatment is directed at the coexisting metabolic disorders. Now, based on the guidelines, we look at some of the drugs. Asia Pacific guidelines, pioglitazone is recommended only in patients with pre-diabetic or diabetic NASH, that too with a limitation that it should be for a short-term use. As per the Asia Pacific guidelines, there is no firm recommendation made regarding the use of vitamin E due to insufficient evidence. Coming to the European guidelines, they advise pharmacotherapy to be reserved for patients only with NASH fibrosis, that is on histologically stage F2 or higher, or NASH with a high risk of disease progression, that is risk factors like diabetes, metabolic syndrome, elevated ALT. They do not have any firm recommendations for the use of pioglitazone or vitamin E. Coming to the American guidelines, American Association of Liver Disease, vitamin E high dose 800 international units daily they have said can be considered in non-diabetic patients with biopsy-proved NASH without cirrhosis. Now, pioglitazone 30 mg daily can be considered in patients with and without diabetes, again with limitation that it should be biopsy-proven NASH. We will go through some of the common drugs that we have been using in our day-to-day practice. Starting off with the ursodeoxycholic acid, which has been widely used. It is based on the concept that bile acids have a role to play in the pathogenesis of NAFLD. One positive factor here is there is abundant data on the use of ursodeoxycholic acid on the safety of long-term use in liver disease patients. So it's been used at a dose of 300 mg/BD or 150 mg/BD, but no guidelines as of now recommend it. Coming to silymarin, it has been mentioned as a potentially useful treatment for NASH in Asia Pacific guidelines only. but they have specifically mentioned that the optimal dose and the duration requires further studies. Now, some of the because diabetes is it is associated with, like I mentioned earlier, NFLD is strongly associated with metabolic syndrome, and one of the important components of metabolic syndrome is obesity and diabetes. So, in patients with diabetes, we usually use metformin, pioglitazone, and now GLP-1 analogs. So, what is the role of metformin? The role of metformin remains uncertain with respect to NAFLD, though it helps in diabetes control and it has a role in the insulin, it plays a role with insulin resistance. As of now, it is not recommended by any guidelines to specifically treat NAFLD, but you can use it for the treatment of diabetes with NAFLD. Coming to pioglitazone, it has been endorsed by certain guidelines, but with significant limitations. One is that it's short-term use. It is to be used only after careful evaluation. The American guidelines specifically mention that this should be in a biopsy-proven NASH. The side effects commonly attributed to it are weight gain, edema, worsening of pre-existing heart failure, and fractures, especially long-term use in females. The long-term safety profile is not very clear as of now. GLP-1 analogs. New evidence has come that the GLP analogs acting on the glucose-insulin interplay, which has a role in the pathogenesis of NAFLD, to have some favorable results. But the guidelines do not give any recommendation as of now for the treatment of NAFLD, but you can use it in patients with diabetes. Coming to a commonly used drug, because dyslipidemia, obesity, dyslipidemia is part of the metabolic syndrome. What about the role of statins? There is, all the guidelines specifically say that there is no increased risk of hepatotoxicity or side effects for the treatment of dyslipidemia in patients with NAFLD. It can be used safely even in patients with NAFLD, even in the presence of raised transaminases. All of the guidelines agree about the safety of prescribing statins, that is, you can starting newly, or you can continuing the ongoing statin therapy in patients with NAFLD, even with compensated cirrhosis. Now, routine prescription is not recommended in two categories. One is if the patient has got decompensated cirrhosis and if the patient has got acute liver failure. What about vitamin E? The long-term safety profile is not fully established because the long-term safety, there are some studies saying that there is an increased risk, especially with high-dose vitamin E, with respect to prostate cancer and an increased cardiovascular mortality. It is recommended by NICE and the AASLD guidelines, but it is limited to biopsy-proven NASH, especially with the American guidelines. The European guidelines and the AISF guidelines recommend that more evidence is required before any recommendation can be made on vitamin E. In fact, the Asia Pacific guidelines advise against the use of vitamin E in the treatment of NAFL. Surgical options available are, one is bariatric surgery. It is found to be having a role to reduce the steatosis and inflammation, but not on fibrosis. Liver transplant, like any patients with cirrhosis, the etiology of NAFLD also is not a contraindication for liver transplant. Now, a few words on lean NAFLD, which is very common in the, which is more common in the Asian population. It is defined as NAFLD that develops in patients with a BMI less than 23 in Asians or less than 25 in Caucasians. What is the prevalence? 5 to 20%, 26% of the general population in Asia and 7 to 20% in the Western world. It is found that lean NAFLD is more common in the Asian population compared to the Western world. The exact mechanisms are not understood, but some of the mechanisms that have been implicated are, one is dysfunctional fat, that is, these patients with lean NAFLD, that means their BMI is normal, they have more of visceral fat, visceral obesity and visceral fat compared to subcutaneous fat. They have an altered lipid turnover. They have an altered body composition, that is decreased muscle mass. Though they are lean, they have a decreased muscle mass. That is where the role of resistance training will help in this lean NAFLD. They have a genetic background. There is a different pattern. That means there is an alteration of the gut microflora in these patients. Some of the possible causes of NAFLD in lean subjects based on the available literature are, one is the high intake of fructose intake and high fat intake, fructose and fat intake. Metabolically obese normal weight subjects, that means we should not be relying only on the BMI. One should look at the waist hip ratio because the truncal obesity will play a role. Visceral fat plays a role. congenital or acquired lipodystrophy, especially patients on, example, antiretroviral therapy, malnutrition, genetic predisposition, some of the endocrine disorders like PCOD, hypothyroidism, growth hormone deficiency, drugs, jejunal ileal bypass, starvation, total parental nutrition are some of the causes that have been implicated. Now, though lean NAFLD patients have a favorable metabolic profile when you compare them with the obese NAFLD patients, they can develop the full spectrum of liver damage that is described in an obese patient. Now, the data on long-term prognosis is not sufficient with respect to lean NAFLD, but whatever available data suggests that NAFLD is not a benign disease. The general recommendations, like in a patient with obese NAFLD, is applicable in a lean NAFLD patient also, including the adoption of a healthy lifestyle, initiation of pharmacological treatments for the risk factors like hypertension, diabetes, dyslipidemia. Now, habitual physical activity should be emphasized also in patients with a lean NAFLD, because here it's not about weight loss, but rather it is proven to decrease the visceral fat. Now, a few words on the Indian scenario. What has been found is that 9 to 30% of our general population have NAFLD. Obviously, this is going to be even higher in the high-risk population, that is patients with metabolic syndrome. Nearly half of our NAFLD patients have metabolic syndrome. There is a high prevalence of insulin resistance among our population. The higher insulin resistance and the higher hepatic triglycerides in Indians in comparison to other races suggests that the Indians, we are more prone for developing NAFLD. Iron overload and HFE gene mutation do not play a major role in the pathogenesis of NAFLD in Indians. It has been found, it is based only on the minimal literature that's available, that there is a mild histological disease at presentation in Indian population compared to the compared to the Western population. Lean NAFLD is more common in our setup. It has been found that the hepatic fat content of Asian Indians is almost twice the amount for similar BMI when you compare with the white Caucasians. Take home message from my talk would be: 1. The strong association between NAFLD and metabolic syndrome. The fact that NAFLD is an independently associated with cardiovascular morbidity and mortality, and there is an increased risk of developing diabetes mellitus in NAFLD patients. So obviously, we have to do a metabolic risk factor profiling, that is screening for diabetes, hypertension, dyslipidemia, obesity, sedentary lifestyle have to be corrected. They have to be identified earlier and treated so that we can prevent cardiovascular and liver-related mortality. Lifestyle intervention will help in the prevention and the treatment of NAFLD. Thank you very much.
Thank you, sir, for enlightening us on NAFLD. We have a few questions actually. So one question we had been asked was, what is the role of fructose? So what is the role of fructose in the pathogenesis of NAFLD, sir? Does fructose have anything to do with NAFLD?
Sorry, Subhash, could you repeat the question, please?
Sorry, sir, we wanted to know, so does fructose have any role in the pathogenesis of NAFLD, sir?
Definitely. What has been found is, especially lean NAFLD, also in obese NAFLD. Now, I would like to clarify one thing. We are not talking about the fructose that is present in fruits. Understood. The fruits, because in all the diet we say take good amount of fruits. That is minimal. That fructose is minimal and it's not harmful. What we are talking about the fructose is the fructose that is added, for example, sweetened beverages. Understood. 1, 2. Any sweetened items nowadays, they are using large component of fructose. The reason is because fructose can help in the storage of food items. 2, fructose does not leave a lingering sweetness in the mouth when you consume it. So when it is added to the products, it gives sweetness, but it does not leave behind any lingering sweetness, so it doesn't affect them. Third thing is, it also helps in the storage of food products. So when you take the processed food items, when you take the sweetened beverages, the carbonated beverages, the increased consumption of this fructose plays an important role in the pathogenesis of, because you are taking increased carbohydrate, increased fructose, it plays an increased role in the pathogenesis of NAFLD.
Okay, thank you, sir. So actually, we had one more question. So what about, sir, how common is hepatocellular carcinoma in NFLD? Is NFLD independently a risk factor for HCC, or is it only when it becomes NASH only progresses like that? Anything is there?
Like as I mentioned earlier, the slide, NFLD, you have two things, that is fatty liver and NASH. Fatty liver is a benign condition. It just remains as a fatty liver. Only if it progresses to NASH, all of our complications, that means it can progress on to cell injury, inflammation, cell injury, and thereby apoptosis, thereby cirrhosis, and the next stage is hepatocellular carcinoma. So if the patients are only fatty liver, we need not be worried. Only thing we should prevent the progression to NASH. But patients with NASH, yes, there is an increased risk. One, no screening is advised in NASH patients for hepatocellular carcinoma as of now. It is only if they develop cirrhosis. Once they develop cirrhosis, it's just like any other cirrhosis patients you monitor with the alpha-fetoprotein, with the ultrasound, all those modalities, like in any patient. Secondly, there are studies coming in saying that there's just few studies. So the guidelines have not put it into guidelines there, but they have noted these case reports that are coming in, that patients with NFLD, that is NASH, without developing cirrhosis, can develop hepatocellular carcinoma. What has been the literature that is available is 3% of patients with NFLD related cirrhosis can progress on to hepatocellular carcinoma. And finally, conclusion of that point that you asked, the patients with, is there a difference in the hepatocellular carcinoma occurring due to NFLD and non-NFLD? What they have found is because of the increased incidence of metabolic syndrome in patients with NFLD related cirrhosis, that is hypertension, diabetes, dyslipidemia, most of these patients have increased cardiovascular mortality and morbidity. Therefore, if you look at the prognosis of HCC due to NFLD and non-NFLD, obviously the NFLD has a worse prognosis.
Sir, and so is immunization mandatory in NFLD? Like the hepatitis B vaccines and Z vaccines. So, sorry, the hepatitis B vaccines, is it mandatory in all NFLD patients, or?
It is not mandatory. It's a very good question. It's not mandatory, but it is advisable. Why is it advisable is, in patients whom you are suspecting NAFLD, what they advise is, if these patients develop superimposed hepatitis A or B, obviously there can be worsening of the disease because it's a two coexisting conditions. So whenever there are two coexisting conditions, it can worsen. So it is advisable. In cirrhosis, obviously, as per the guidelines of cirrhosis, all the adult immunization, even in a fatty liver or a NASH, it is advisable. What they advise is at least hepatitis A and B vaccination if the patient has not suffered from any of these in the past, or if there are no serological evidence of immunity, it is advisable to go ahead with vaccination, even in a patient with fatty liver or NASH.
Okay, sir. And so we have heard of DASH diet in hypertension. So is there any role for DASH diet in NFLD?
Yes, they have compared the DASH diet and the Mediterranean diet. What you asked is a very good question. It's the Mediterranean diet is more of fruits, vegetables, nuts, avoiding processed food. DASH diet is restricting because it was basically used for the control of hypertension. It is restricting the salt intake to 2.4 gram. The same thing like fruits and vegetables, but the DASH diet gives a little more leeway. That means increased intake of the in the dairy products compared to the Mediterranean diet. When they compared it, it's also got equal effect on the benefit, not only on the NFLD, also on the metabolic risk factors. But one thing everybody has compared is it should be ideally along with the exercise.
Okay, sir. Thank you, sir. Thank you very much for your words, sir. And sir, now we will conclude the sessions, academic sessions. Thank you, sir.
Thank you very much. Thank you.
So we have come to the end of our academic sessions. Initially, we had a few glitches, some echoing and all. Please bear with us because this initial problems are not anticipated. So we wish you can join us later at 7 p.m. for the live case discussion, where we'll be discussing a neurology case at 7 o'clock. Till then, thank you. Thank you. Thank you for joining. One more thing I would like to add is if there is if there are questions which you have not answered in the chats, we will get across and we will answer these questions later. Today, because of the time shortage, it's already 5:40. We are really much behind schedule, so we will be answering them through the chat box or even directly to the people who have asked. Thank you.